as grateful as I am for the constituents in the room right now, really the key stakeholders in this are really going to be our residents, our EPPs, our people who do most of the documentation in our department on the outpatient, inpatient, and so forth. And Dr. Catalano is an expert in sort of the way in which we can capture that better. And he's part of our consulting group's recent task to try to improve what they call documentation excellence, which is even at low-lying fruit level, we're talking about $100 million at UW Medicine that we could easily capture with better documentation, not changing a single thing about what we do about our care whatsoever as an enterprise. And I just wanted to put in that context because this is so important. And at our departmental level, it's maybe more important than average for a surgical department because we do such a subpar job of doing the outpatient and the clinical documentation piece, but it makes such a big difference on the hospital end, not so much on the pro fee side, but it really makes a huge difference on the DRG capture and a lot of the revenue generating things. That whole world is changing because we're moving away from fee for service to a more of a value-based bundle payment model, but this makes this sort of work is even more important in those endeavors because you have to prove what you've done and that you've captured a higher risk population, all that. Otherwise, all the metrics by which you're judged are off, if you will, in the sense that they don't think you should be costing as much care as you do because your patients aren't that sick, when in fact our patients are much sicker than average. And we just need to do a better job capturing that. So anyway, I'll just put in that context.
And then I'll quickly introduce Dr. Catalano. Dr. Catalano has decades of experience as being a physician, executive and consultant. He started his medical journey at Loma Linda University, and then went on to do obstetrics and gynecology in Glendale, California, and then was recruited. I was talking to him just before this happened. He's been recruited to be both a CMO and medical director of different programs. His work in quality, as well as in the coding, documentation, and integrity space, has been extensive over the last 17 years. He's implemented these programs across over 100 hospital systems in the United States, whether it's implementation or refinement. And I've got the chance to hear Dr. Catalano speak previously. It was excellent. And what I love is he's a surgeon who understands surgeons. And so his talk is really focused towards our group. I can't tell you how important this is when it comes to capturing the patient population that we are treating, what it means to whatever hospital system we're in, or whatever hospital system any of our residents and groups go to. It is critical that it's a partner with those hospital systems. You understand this, all right? And with that, I'm happy to introduce Dr. Catalano.
Thank you, Brian. Thank you for your time, Brighton. I was going to say bright and early, but early this morning. So my background is pelvic reconstructive surgery. I practiced for many years and I left to be a chief medical officer. And the reason I'm telling you this based on what they had already said was because there's something I need to let you know additionally, and that is, as I sat as a CMO watching and discussing quality metrics with the boards of the medical staffs of my hospitals, much to my shock and surprise, shock is probably not the right word, dismay and surprise, quality metrics are not based on actual outcomes. They're based on the word we use to describe our patients. And I'd never heard that before. This is many years ago now. And so I did a deep dive to figure out how do I fix the problem. And what I found out was we needed to be better at the words. We learn in our training how to be excellent at doing and excellent at diagnosing, but we don't learn how to prove we're excellent. So from a quality perspective, we have to get the words in the chart that are going to say, this is what our patients are really like, as opposed to what we all learned, which is a blinder that says, this is what I need to do with this patient, this is what I'm doing with this patient, and so on. Now, that's a frustration for lots of us, those of us who practice and who finished some time ago. It's a frustration to be able to hear that we have to be more proficient at the words captured than what we have been. But for an academic university medical center, you really want to make sure that the picture you're painting is going to be accurately representing the complexity of your patients. And as was said a little bit earlier, the value-based purchasing part of this, you may not realize that the Affordable Care Act has something in it that says surgeons will stop being paid on the global fee and will start being paid on a severity basis. That's what the rest of medicine has been paid on for since 2008 at least. And that means that we have to be good, however we get there, at documenting the severity of illness of our patients. And so that's what this is really going to be about. Now, the first several slides, you all will receive a PDF of the slide deck. So if I go through some of them faster than you had something you want to see, you will be able to review it. I'm going to go through them fairly quick because I have a lot of information in a short time to be able to go through, and I don't want to talk too fast. There isn't anything from a disclosure perspective. There's not a financial impact. I'm actually not a employee of Solventum, which used to be an arm of 3M. They spun it off last April 1, and there isn't anything we're going to talk about related to use of any materials that 3M makes. We're not going to talk about any of that at all. This is actually about the words you use in the chart, not about the codes you pick for your procedures or the codes you pick in your office. It's not about coding. I don't believe you should be excellent coders, and you believe you should be excellent documenters. And so who's in training? Who's fellow or anyone?
Resident.
Two residents. Okay. So you have the opportunity to get good at this now, because those of your colleagues who are beyond that point have to learn it this way. You can learn it on the job where it's not actually affecting your actual picture that you're painting, but you are painting a picture that your attendings are going to be affected by. And so we're going to talk about that as we go through this. There are some tools in here that are copyrighted, so there's a copyright notice. These are our objectives, and this isn't about, as I said, making you excellent at coding. This is, in fact, there might be a couple codes in here, but that's specifically to say there's a difference between this term and that term. Otherwise, it's not anything that I want you to be able to see about that. But these terms, severity of illness and risk of mortality, are very big in your quality metrics. So we want to make sure that you understand how that's happening. And you are able to use this anywhere within UW Medicine. You just can't take it outside of UW Medicine. So if there's something in here that you are going to do a presentation, you want to use 2 or 3 slides from this, you're welcome to do that. When you're documenting, those words are leading to codes. Those codes are leading to data. That data is leading to profiling. The profiling says, how do you look compared with each other? How do you look compared within the region? How do you look within the state? How do you look within the nation? And for UW, how you look at the nation is an important thing. I did this at the Mayo Clinic in 2011. The CEO of the Mayo Clinic said, there's one thing we want to get from this, Dan. One thing. Can you guess what the one thing is? And I said, you want to be number 1. And he said, exactly. They wanted to be, and it took them 4 years. Because what I'm going to show you, some of these metrics are a rolling 3-year average. That means you have to get past 3 years of data that didn't accurately capture what it is you're doing before you will get to where the truth is really. Because if this is truth, and this is where you are, you're on a journey to truth. Above truth is called fraud. Okay, it's called fraud. We're not trying to make your patients look more complex than they really are. We're trying to, however, get you to the point where you are getting truth in terms of the credit for the severity of illness, the risk of mortality, the length of stay, and so on. All of those are coming from the words that you use. Typically, mortality, complications, and resource utilization, which uses a proxy of length of stay, are the metrics that are used in comparison data. So we'll talk a little bit about those. And there's often questions about how does this actually improve the care process? How is it that this affects the patient in the bed right now, being better at documenting? And the answer is, in the observed over expected equation, documentation usually improves the denominator to truth, whatever that is. The numerator actually gets better as well because the length of stay shortens. That's an actual. The length of stay will go down because of better throughput, better communication. The complication rate drops because of better communication. So everybody's on the same page. As the quality people would say that you're all in the same script or in the same movie. So it does improve the care processes. So these, I put it right up at the front, the 5 things not to forget related to the documentation. Now, from a surgeon perspective, especially if there are others who are writing the notes. So for the neurosurgeon attending, it might be that the only note that you do is the operative note. And that means all the other notes that are going to be painting a picture of your patient, you're the attending, all those other things are going to come from others, which means that hopefully all those others are hearing this information now as well. Build a better H&P. Number 1, that came from a CT surgeon in the largest hospital in Pittsburgh who said after about 6 months of helping, trying, oh, so what you're saying is if our H&P better reflects the conditions the patients have before we operate on them, number 1, we'll get fewer queries after we operate on them. That's true, because you won't get queries about what was already there. Number 2, your quality metrics are based on present on admission, POA, number 3 on this list. POA says it was already there. It's already there, can't be a complication of your surgery. So building a better H&P says, make sure that not only the principal diagnosis, the reason why you're going to be doing the surgery, but also the secondary diagnoses that you know at the time the H&P is done. And we'll talk about a few of those. that you could know beforehand that make a difference. The second one then becomes pretty obvious. If you think about it and you act on it, but you don't document it, then it cannot be used in the picture you're painting of the complexity of your patient. So I'll give you a very common example for surgeons. I was meeting with the general surgeon. This was actually probably before COVID now. And the patient had a sodium of 129. And this was on site. I asked him a question. I said, I have a question about this patient. Has a sodium of 129. He put his hand up and said, Dan, I'm trying to be nice, but I really don't care. I do not care. And I said, no problem. Just one quick question for you. Why did the IV solution get changed from half normal saline to normal saline after the sodium of 129 came? And he put his hand up again, and I saw the light bulb come on. And he said, because I was treating it. And if you're treating it, it's a valid diagnosis that contributes to the picture you're painting, even if it seems like it's a minuscule thing relative to all of the other major circumstances that are going on with that patient. Number 3, POA status, present on admission. See that in parentheses, that's very important. Present on admission means it cannot be used as a complication of your procedure. It cannot be used as a hospital-acquired condition, a HAC. You may have heard that term. It's a government program that's intended to measure who has higher complications and penalize hospitals who have higher complication rates. So something that was present on admission, but wasn't documented in the H&P, and when it was documented later after the H&P, they didn't indicate that it was POA by putting a little parentheses POA after that, results in it being, when the coding process occurs, that it was not present on admission, and not present on admission allows it to be considered a complication of care. Number 4, for your mortality statistics, any diagnosis that a patient could die from, whether or not they die, contributes to the denominator in the O over E for mortality. The numerator is what it is. There's only 2 values per patient. A 0, they didn't die, and a 1, they did die. The denominator, however, has nothing that you can do that will give you a 1 in the denominator. That means you need to have lots of patients that could have died, that didn't die, in order to have an O over E, an index that says we're better than average. And then number 5, clinical validation. Clinical validation is probably the most important term for both the providers and for the hospital. For those of you who practice long enough that you have remember paper records and so on, that for many years, for decades, providers and hospitals were paid for a list of diagnoses and our bill. They might argue about the amount of the bill, but the list of diagnoses, our word was to have these and you got credit for it. That's not the case anymore. And the reason is the electronic healthcare record allows you to produce a list of diagnoses without necessarily having done anything about it. You go click, click, click in the patient's e-problem list, and your template says everything I clicked on I want to show up right here. That doesn't say you did anything about it. So that list, the active hospital problem list, is not used as the list of diagnoses your patient has. And Dr. Wiseman and I talked a little bit about the problem-based charting, and you're going to hear more about that, not from me because of time-wise, but problem-based charting is a good way to use the assessment and plan problem list as the place that you collate all the diagnoses that your patient has. And in building a better H&P, if those diagnoses go into the assessment and plan problem list, rather than active hospital problem list or past medical history or history of an HPI, then they're in a position to be able to move forward and be able to be seen by others. That's part of that quality perspective, and also to make it into the discharge summary, which is another thing that we will talk about in a little bit. So clinical validation says, why do I think what I think? I love the words as evidenced by. Diagnosis as evidenced by, and here are the clinical indicators they have. Whether it's a medical diagnosis or a surgical diagnosis, there are always clinical indicators that are leading you to say, this is why I believe that they have this. When you've done that, you've validated the diagnosis when the last part is added, and that is, what do I plan to do about it? What did we do about it? Are we doing about it? And what have we done about it? Those two are required for every diagnosis at least one time, somewhere between the H&P and the discharge summary. So if they're in the H&P for those secondary diagnoses, so patient, problem number 6, patient has hypothyroidism and will remain on home dose of Synthroid while hospitalized. That's the validation for that. And you don't have to say it again until the discharge summary. You don't have to say the Synthroid part, just the diagnosis and the discharge summary. Now, there's also an opportunity related to conflicting documentation. If you say as a neurosurgery service, the patient has ABC and someone else who's, whether it's hospital medicine or consultant, says XYZ, and they can't both be there at the same time, that's called conflicting documentation. What's the problem with that? The problem is twofold. Number one, when the coding professional goes to assign a code, if there's conflicting documentation, they need to resolve that. Who do they ask? By law, the attending is legally responsible for the accuracy of the record. So the fact that the attending wrote one note, the operative note, or did one note, and then didn't do the rest of the notes, the attending gets the query about a week after the patient's left the building and answers it with, I don't know. I didn't do the discharge summary. I don't know, I didn't write the notes. And whatever was being asked is now lost. They will not assign a code to it if the query wasn't answered with some response related to what the question was driving at. So conflicting documentation needs to be resolved prior to the discharge summary being done. The other issue for conflicting documentation is that payers love conflicting documentation because they say, oh goody, we get to pick the one we want. So if you have a patient who has the description in your physical exam in your H&P is cachectic impairing. The actual diagnosis that goes with that is severe malnutrition. So let's say severe malnutrition is in the assessment and plan problem list. And then somebody else leaves the template language and says well nourished. So they say alert learning times 3, well nourished, and no apparent distress. Those 3 are very, very common sources for a payer to make a denial of very significant diagnosis that goes along with that. No apparent distress in the patient who has an acute abdomen or has acute chest pain, or who has encephalopathy would be the, or alert learning times 3. I have one slide, it's not in here, one slide that says alert learning times 3 and the patient's comatose because they left the template language in. You cannot do that because what you're doing is inviting the people who pay for the care to say, oh, okay, well, it's here, so we get to count it. Now, if you have template language like that, I'd suggest you actually remove your template, but you have to always remember to remove that. And then the last one is making sure the discharge summary is comprehensive. This is a leap for surgeons. My discharge summary said I called, I cut, I conquered. And that's basically what we do when we're saying we're focusing on what we brought them in, what we're doing, and that is done, and hopefully we did it successfully, and they're going home. The problem is that all those diagnoses that need to be in the discharge summary are then missed. And by law, the coding professional has the right to ask the attending of record. That's the attending who either does the discharge summary or attests to the discharge summary, has the right to ask them any question that they might have before they assign a code. If you don't answer, if they ask you if it was a complication of care and you don't answer, the default is it was a complication. If they ask you if it was POA and you don't answer, the default is it was not POA, which means it can be considered a complication of care. So you want to make sure the queries are getting answered, and as you're attending, you don't want to get a retrospective query. That's the query that comes after the patient's left the building. It's much harder to answer. It takes much more time to answer, and frankly, most of us wouldn't do it. We would just say, wasn't me. Yes, sir.
Does the documentation need to be in the H&P and the discharge summary? Otherwise, it's not going to be included by the coders, or is it going to be anywhere in that mission?
It's a great question. So anywhere between H&P and discharge summary, put in the chart by a licensed by the state, privileged by the medical staff provider who has hands-on care. Now, hands-on care is important. If you have a neuroradiologist who gives you a report, copying and pasting that into your note doesn't do any good because it's someone else's work product, even if you sign your note. But if you, and we're going to talk about the concept of endorsement coming up very shortly here. If you take the diagnosis that you gleaned from any other source and you put it into your assessment and plan problem list, that says as the attending service, I believe that this diagnosis is present in this patient. And again, we will address that. They can get it from anywhere, beginning to the discharge summary. Yes, sir.
So it seems like the problem you're driving at is that you have to be beyond semantically adroit. You have to use the words that they want you to use. So when I say the guy looks cachectic, to me that's a diagnosis, but you're saying it's not. So we need a place, we need to be able to look this stuff up.
You actually don't even have to do that. It's even better than that because Brock has a team whose full-time job is to be your backstop. Their job is to let you know when they find exactly what you just said. You said cachectic appearing, and then they're going to not only tell you that there's something more specific, but they're also going to give you the details. The dietitian said this patient meets criteria for severe malnutrition is evidenced by weight loss of 7%, blah, blah, blah. And you can then use from the query, you can get the answer into your assessment of plan problem list without having to do all of the legwork behind that. The semantics part's absolutely true. There isn't any question about it. The coding rules, the ICD-10-CM, that's the US version of ICD-10 that the rest of the nation uses, has very specific words that have to be there for the coders to assign a code to that. And we don't. We have a lexicon that allows you to say the patient has hemoglobin 6.8, transfused 2 units of packed red blood cells. Now everybody in this room knows exactly what I just said. But the coder folks cannot assign a code of even of anemia to that, even though every person doing a job as a coding professional knows that hemoglobin 6.8 is anemia. They can't assign it because they'd be making the diagnosis. And there has to be explicit documentation of the diagnosis in order to be able to assign a code. And you're going to see, coming up very shortly here, you're going to see the difference it makes related to the specificity of diagnoses when it comes to giving you credit. Okay, so this is one of the common queries. Was this clinically significant? And probably the most common one for neurosurgeons is somebody noted midline shift or mass effect. Midline shift or mass effect doesn't go anywhere from a severity perspective because it might be a little or it might be a lot. But if there is something that you're doing about that, even if it's just following it up, even if you're not actually taking it to the operating room, but if there's a deficit from it, or that you are following it to see if it's enlarging, then that makes it a valid secondary diagnosis. But the diagnosis isn't mass effect or midline shift. It's cerebral edema, or it's hematoma or hemorrhage, or whatever the circumstance might be there. And they give you credit for what you do, world. That is what you get measured on and compared on around the country. These are the rules that the federal government has set up to say whether or not it's a valid diagnosis. So in my example of the hyponatremia, it was being, it got a clinical evaluation and then it was being treated. Now, if you put a patient on their home meds, almost for certain, you didn't make the diagnosis for which they're taking those home meds, but you still chose to treat them when you put them on their home meds when they were in the hospital after the procedure was done, or if there wasn't a procedure or while the patient was being monitoring. We're going to talk about what that's called and how you do that. The rest of it is pretty self-explanatory. You notice the word monitoring down here. That's where I'm saying, if you're monitoring a patient who has a midline shift by doing sequential studies, then that means that whatever that diagnosis is, whether it's edema or whether it is blood that's there, that's going to be a valid diagnosis to be able to use. And the patient who has a hemoglobin of 6.8, there was a patient at Indiana University when I first started doing this that had a neurosurgical procedure, and the operative note said EBL 3000 cc's, complications none, findings, whatever the thing was, and the patient got 8 units of blood intraoperatively and 5 units of whatever they were giving them postoperatively. And I went to him afterwards and I said, I have a couple questions for you. I said, first of all, what was it that was 3000 cc's that was expected? He said it was an AV malformation clipping. The clip didn't go all the way across. And when we cut, there was a high pressure flow and it took a while to get it cleared up. And I said, I'm not a neurosurgeon, so whether that's a complication or not, it's up to you. By the way, regarding complications, there's 2 types of people who do procedures: those that have complications and those that are not telling the truth. We're going to do procedures. Exactly. I've not had a complication in quite a while, and I haven't done any procedures, but they do happen, and we know that they happen. That's a quick aside. So the issue is that we want to make sure that those diagnoses that are contributing to the picture are going to be documented here. And if we're monitoring, so if we're doing the H&H, as I said, we're following H&H on a patient, even if we don't end up giving them blood or blood products. If their hemoglobin is less than 10, they meet the criteria. And if you're following it to see if it's dropping or going up, then it's a valid secondary diagnosis. And that means that you get credit for it, even if it didn't seem like a big deal. So the goal of all this, paint a picture that's going to be right on target relative to complexity of your patient, the severity of illness, the risk of mortality. So the picture you're going to paint, your quality picture, as well as your remuneration picture, is going to be an accurate representation of what's happening. So this is what we talked about earlier, the observed over expected equation. You might not realize that the denominator of this equation is based entirely on the words we use to describe our patients. If we underrepresent the risk of something happening, the denominator will be smaller. Length of stay. So we were talking about length of stay concerns. The patient stayed for 8 days. The expected length of stay was 3 days. Why did they say 8? Probably there's other diagnoses that contributed to that. That's what we're talking about, is making sure that those diagnoses are going to make it into the record so the denominator is going to more accurately reflect. So you're going to hear this again, I'm sure. Better documentation doesn't send your patient home sooner. It explains why they stayed as long as they did. And that's important from our perspective, because I don't like the wet noodle saying they got to go home. They got to go home, we're out of days. But if we can explain that they're staying longer because they have confounding diagnoses, then that's important. So there's 2 profiling systems that are in use in the United States. I'm going to explain this very quickly because I'm going to show you data, and you have to understand where the data came from. So the MSDRG, Medicare Severity Adjusted Diagnosis Related Grouping, takes the principal diagnosis. That's about the bed. For your neurosurgical patients, generally, it's going to be the diagnosis that was identified either from the emergency room or out in the outpatient world that brought them in. For a trauma patient, it might not be the same circumstance. It might not be the principal diagnosis, but the principal diagnosis is about the bed. And then the secondary diagnoses are labeled as major comorbid conditions. That's a high contributor to relative weight. A comorbid condition, or CC, that's a average contributor, or nothing, baseline, that doesn't change the relative weight at all. What's the relative weight? Relative weight is the number that's calculated when the patient leaves the building and the coding process is done. And the principal diagnosis, the DRG, secondary diagnoses are all assigned codes. And that allows the relative weight to be determined, the length of stay expectation to be determined. These are the numbers that go into the denominator based on not just the principal, but the secondary diagnoses. It's relative to every other patient in the United States that has the same diagnosis. So now it's comparative data. Now there's a more useful comparative data that's called case mix index, CMI. And CMI is the average of the relative weight. So for the attending, for 6 months, we add up the relative weights of all of your patients, and then we divide it by the number of patients in that cohort, and that's called your case mix index. And you have the same thing for the neurosurgical service line, you have the same thing for the surgical division, and you have the same thing for the hospital. And now that's comparison data across the board. So here's just a list. I'm just going to click through this very quickly in the interest of time. These are things that are the CC level, and these are the things that are the MCC level. And you notice that the semantic modifiers, the words acute or severe, are generally going to be higher in this profiling system. Chronic is usually going to be the baseline or the comorbid CC condition, and acute is usually going to be an MCC and sometimes CC, depends on the diagnosis. So how that contributes to the relative weight then is important. The second profiling system is called APR-DRG, all patient refined, and that simply means from birth to death. So the MSDRG was designed from age 18 and older. This is designed for everybody. And what this does is it takes two subclasses, severity of illness and risk of mortality, and divides those into four subclasses, minor, moderate, major, and extreme. So it's much more granular than the MSDRG, which has only 3 levels, and sometimes only 2. And so when you admit a patient for a craniotomy, they're a 1 and a 1. When they get admitted by your CT surgery colleagues for a CABG, they're a 1 and a 1 within the DRG for CABG. When they get admitted for pneumonia by hospital medicine, a 1 and a 1. Everybody starts off at 1 and 1. Keep that in mind, because what do you think makes a patient become a 2 or 3 or 4? Comorbidities, secondary diagnoses. The one thing that we are least proficient at, especially as surgeons, because of we're focused on what it is that we're bringing the patient in for. Which means that every time we leave out comorbidities in our documentation, somewhere between H and P and the last stage progress note, when we leave those out, we're underrepresenting the severity of illness and risk of mortality. So who uses this? Everybody in quality. It might change a little bit in the near future, but right now, everyone's using the APR-DRG. This is the underlying principle. Patients with multiple serious diseases generally have higher severity of illness and risk of mortality. So if you have a neurotrauma patient and they have other trauma, then those are other significant diagnoses. But if they have diabetes, or they have hypertension, or they have kidney disease, those are also secondary diagnoses that are contributing to that patient having an increased risk of staying longer or dying, or complications, and so on. So we're going to use anemia as an example of a secondary diagnosis. This is probably the most common query that surgeons get across the country. Patients noted to have a hemoglobin of 6.8, and there's no diagnosis associated with this, and so on. So if your patient came in for whatever the neurosurgical procedure was, and you say anemia, remember your patient was a 1 and a 1 when you started, they're still a 1 and a 1. What does that mean statistically? It means they look exactly like a patient who had the same surgical procedure who doesn't have anemia, who isn't getting monitoring of H&H's done, or who isn't getting blood, and so on. So acute blood loss moves them up to a 2. Now for neurosurgery, you often have patients that should be 2s or 3s and 4s. For me, that may be the only thing that makes my patient go from a 1 to a 2, is if they have an acute blood loss anemia. Does this automatically mean it's an oops? We're going to talk about complications coming up. So if the patient has, for whatever reason, neutropenia due to drugs. Now neutropenia unspecified, you notice is a, neutropenia unspecified is a 2, and neutropenia due to chemo would be a 3. So if you have a patient who had chemotherapy and they have neutropenia or pancytopenia due to chemotherapy, that's going to make them a 3. And occasionally hemorrhagic shock or consumptive coagulopathy, that makes them a 4 and a 4. Now where you see the 2 asterisks or 1 asterisk, this is an MCC and this is a CC, just so that you can combine the APR-DRG, you can see those diagnoses.
I have a question.
Yes.
Can you go back? Can I go back to the last slide? So if you have a patient and there's acute blood anemia secondary to the surgery, would that still move the patient from
Yes.
6 to 2, or is that?
Yes.
Okay.
Anytime the diagnosis is there, regardless of how it got there. Now, when you say due to surgery, are you saying it was a oops from the surgery, a complication of the surgery, or are you just saying the patient had a surgery, like they had multiple levels, spinal fusion, and they have a acute blood loss anemia afterwards, which is very typical.
Does it make a difference?
It doesn't make a difference in this system. It does make a difference in your complication O over E, because the numerator goes up by 1 with oops. And we're going to talk about that because it's a very significant reason why you don't look like you should look. in terms of complications. It still gets counted the same, it still gets counted in both profiling systems. If the diagnosis is there, regardless of how it got there, it still counts.
Thank you.
Okay, so this is a very important concept then for surgeons, concept of endorsement. I may not have made the diagnosis, but I don't have a reason to disagree with it, and the patient's being treated for it. Now, I have to be careful when I say the next thing, because most of the places where I say it, or many places where I say it, the answer is already fairly obvious. If you go, when you have sent somebody to the path lab, and you go and you sit down next to the pathologist, and you look at it under the microscope, and then you overrule the pathologist, then that's not what you're doing here. But if you get a path report back from the pathologist, and you say, well, they're a pathologist, they're a neuropathologist, and this is what it is, then you're endorsing their opinion. This isn't anything new. It's just a word that I put on it to give an idea, a label to say, no one's asking you if you agree with it, meaning you could make the diagnosis. They're asking you, do you have a reason to disagree with it because it was made by somebody who has expertise in that area. So when the neurosurgeon has a patient that has a cardiology consult, the cardiologist says acute on chronic diastolic heart failure. They had chronic diastolic heart failure beforehand, lots of fluid shifts in the surgery, and when they wake up, they have some shortness of breath, and there's a chest X-ray that shows some pulmonary edema. You get the cardiology consult, the medicine consult, and they say acute on chronic diastolic heart failure. And you say, thanks for the consult, right? That's what we all learn. Appreciate cardiology consult. The problem is that that diagnosis is in their consult, but it's not in the attending services assessment, which means it's less likely to get into the short summary. But if you endorse it by putting it into your assessment plan, you can say acute on chronic diastolic heart failure per cardiology, being managed by them. You don't have to say anything more about it till make sure it gets into the discharge summary.
I occasionally get consult notes from other services sent to me to co-sign. Is that the same as me endorsing their note, or does it actually have to be in?
What I'm talking about here, endorsement,
Yeah.
means putting it into your assessment plan.
It has to be in,
co-sign.
our services
Yeah.
note.
But the reason is this, when you sign it, you might be saying, I'm recognizing it's there, and that's okay. But when you put it into your service lines assessment plan, it's going to make it into the discharge summary. Statistically speaking, if it's in the last day's progress note, there's a near certainty it will be in the discharge summary, regardless of who does the discharge summary.
What about for patients that are co-managed, particularly in the intensive care unit, where there's a neurocritical care attending that is clearly managing a scope of care and a neurosurgery attending? Where does the differentiation notes lie for endorsement or any of these?
Who does the discharge summary in the patient? Might it depend.
It depends. Most of the time, these patients will end up on the ward and then be discharged by neurosurgery.
So
It's
neurosurgery.
really who does a discharge summary? That's what
Yes, exactly right. Whoever, and the attending, even though they didn't do the discharge summary themselves, they attested to it. That's the one who gets the glory or the ding for everybody else's work. All those other service that were there, all those severe diagnoses, the attending service is the one who's going to get the relative weight associated with all of those very significant diagnoses, which means that the attending of record wants to make sure the discharge summary is comprehensive, because they're the ones personally that are going to actually get that as well. So that means that when you do an attestation for the discharge summary, you're not likely to take the time to be able to go back and make sure it's accurate and specific. The way to fix that is to make sure that the last day's progress note is accurate and specific, because that's going to be able to be moved right into the discharge summary. And since you have a member of your staff who has the keys to the kingdom, that's what I call the people who know how to use Epic and make templates and make smart phrases and so on. Then what you need to be able to do is to use a template in the discharge summary that takes it from the last day's progress note and puts it right in the discharge summary. That makes it very easy to do and makes it comprehensive at the same time. Instead of I called, I cut, I conquered, it's now I called, I cut, and here's all the things that they had that contributed to their longer length of stay. And then you won't end up having a profile that shows something different. Does anybody have any questions about the concept of endorsement? Remember, the key here is disagree as opposed to agree. They're not asking if you can make the diagnosis. They're simply saying, is it present?
I just would say, not to be too contrarian here, but I think that workflow that you just described is not our workflow. You know what I mean? Like even doing what you just said would be a cataclysmic change in how attendings function in the medical record right now.
It will probably happen, and the reason it will happen is because you care how you look, and the way you look is not an accurate representation. I don't mean you personally, I mean service line wise, university wise. The way that you look is probably not what you want it to be. So most of the clients I work with are academic university medical centers and large multi-hospital systems, which are often affiliated with academic university medical centers. And the goal is not just to do an excellent job, but it's to prove you are excellent at what it is you're doing. And that comes from the words. Now, the benefit of having somebody who is an expert in how to use your electronic healthcare record is that you will have less significant sea change, major changes in how you're processing. But if you don't get those, you will still continue to underrepresent what it is that you are doing. And you know, you can say we go from a paper record to a electronic record to a more sophisticated electronic record. The entity that I was a CMO, they spent $500 million going on Cerner, now spending $1 billion going to Epic, because they want to make sure that they're going to be able to use the tools that are there to paint that
What I'm
picture.
getting at is that the real change management problem isn't knowing all these terms and putting it in there and doing the work. The real thing is changing the workflow that gets those things
You
in
and I
there.
agree with that. We agree.
And so this is helpful, but I think in the end, the change management part is really gonna be, how do you get surgeons to write a note on the last day of admission that then has all these diagnoses in it, you know?
Make sure that the diagnoses are there each day as they show up, and use the assessment and plan problem list as the place that you collate those. And that comes from the whole team, not just from the surgeon. It comes from the whole team. Your advanced practitioners, your residents, your fellows, knowing that when I see that cardiology consult, I don't write in my note, just appreciate cardiology consult. I endorse, unless there's a disagreement, I endorse the diagnosis. Once it's there, it just moves forward. You don't even have to deal with it again. And if you are using Epic the way that it was designed, you can then take it from that last day, which was in the first, second, third, fourth, fifth day, and it'll show up in the discharge summary. That doesn't take more time. It actually takes less time. Yes.
We don't have to get too off topic here, but I think the bigger problem is not the workflow. I think it's salience. How do you get any of us to care? Right? Like, I know you say, oh, payer mix or not payer mix, but like patient mix, and like, oh, we look worse, but none of us know how we look. Doesn't impact us at all. How do you make it salient?
So
It's not salient to any of us.
So hang on a second, and I'm going to show you this.
Maybe.
You'll be able to
No, I
see.
mean,
No, I should hear, basically what you're saying is the same as that surgeon that said to me. Great, but it doesn't matter to me. So I'm gonna hopefully give you some information that will matter to you, because it is basically how you look.
There is a question. You want to address it now or
Yes,
you
go
want to
ahead.
wait? So the question is, does a diagnosis from an ICU stay need to be in the discharge summary for it to be
Yes. Yeah. The diagnosis,
used? That's from Dr.
yeah.
Floyd.
The coding professional, if it's not in the discharge summary, is gonna ask the attending of record. And if you weren't in the ICU, you were after that point, you might say, I don't know. But that's why keeping that assessment plan problem list as the place that you codate all the diagnoses on the day that you know them allows this to happen. Okay, so this is an example of a patient where you can see the clinical vignette over here. This is the MSDRG information. This is the APR-DRG information. This is what they had said initially. Neoplasm of uncertain behavior of the spinal cord. The patient underwent this procedure, and the path report came back and said it was pilocytic astrocytoma. Now, this goes to a DRG of 981. This goes to a DRG of 028. I will just tell you, just for information's sake, that the lower the number is, the higher the relative weight is, just so that you know, okay? Relatively speaking. The relative weight was 4.58 with this information before the query was asked, after the query was asked and answered. What happened here was that the neurosurgery team got a query that said, the path report coming back with this, do you have a reason to disagree with it? In other words, do you endorse the diagnosis? And they said, no, we don't have a reason to disagree, so they put it in the record. Pilocytic astrocytoma, and the relative weight went from 4.58 to 5.88. 8.5 days to 9.8 days, so a full day plus added to the expected length of stay. They went from a 1.8 severity weight to a 2 severity weight. So those are all used in your compression data. Yes.
So when we get these diagnosis clarification questions after discharge,
Like the path report.
like the path report, for
Right.
example, or if it's like someone who came in with cachexia or anemia, whatever, and we sign it after the fact. Those, I'm not updating the discharge summary typically to put those into the discharge summary, but they wind up as co-signed notes in the chart. Do those count, or are they?
As long as they end up in the encounter record, that's the H&P to discharge summary. Even if you get it afterwards, if it ends up in the encounter record, then it can be assigned to code. In fact, the coders will recode the chart. If they've already coded it and then this comes back, they'll recode it with a different DRG.
So I'm a little confused then, because you said before that for it to count, it must be in the discharge summary.
So when you get a query after the patient's done and the discharge summary, let's just say the discharge summary is already completed in the patient that you're talking about. The way that it gets into the record somewhere between H&P and discharge summary is either by an addendum being done to the discharge summary or some policy and procedure that your system
Yeah,
has.
so the CDI inquiries that you see actually do then get reattached to the record. So the record is now updated. So if you just say, I agree, and they give you a little thing to co-sign, that actually addends
And
the
then,
record.
and in that circumstance, then even though it's not in the discharge summary, it still is going to be assigned to code because it is after the discharge summary is done, it's completion of the record.
So it seems like then if documentation in the critical care notes would add to complexity weighting and stuff. If the CDI processes went through and did similar coding clarifications for that, that would also help capture those things.
They do that in the ICU. They do that. The issue is when it's beyond the discharge. When it's beyond the discharge, then that's when you get that query that's going to usually be, when you answer it on the query, that query is now going to become part of the record. That's going to now say it allows it to be assigned to code. And typically that's going to be a more specific code. It's not something new usually. It's something more specific. Mass gives you the credit of the lipoma on my elbow, and cancer, of course, is much different.
Yeah, but I'm not trying to like parse this too fine. I'm just really confused. So if in the ICU patient has acute respiratory failure, that's resolved, they go to acute care, and then acute respiratory failure is not mentioned in the neurosurgical discharge note. Acute respiratory failure does not contribute to the ERG weighting unless it is mentioned in the discharge summary.
The attending is going to get a query. That's going to say.
I've never gotten a query for that.
Yeah.
So I'm just saying, I think there's certainly an opportunity here for all these ICU diagnoses. Yeah,
Probably so. In fact, there was another question.
Yeah, I was just gonna say, your example shows how it all boils down to verbal alacrity, because a JPA is not a malignant neoplasm, it's benign, it's a grade 1. So see, I mean, that's the problem, is translation, and it all
Don't
gets
get
lost in
lost in the weeds there because I don't know. I'm not a neurosurgeon and I'm not a pathologist, so I don't know what happened in the translation to the coding. If you go down that path, then we'll get stuck with were they right or wrong. And that's my point, is the words need to be there in the record that are going to, as accurately as you know, reflect it. And if you get a query, it's because the people who do the job that work with Brock, their full-time job is to be your backstop. They're the member of your team who knows stuff you don't ever want to know about coding, about compliance, about medical legal, about quality. So when they ask you the query, they're simply saying, there's a gap here. I'm letting you know. You get to decide as a team or as a provider, depending on the circumstances, you get to decide how you want to be answering this. And if you choose not to answer it, then nothing's going to change in the chart. And that will lead to whatever they thought was present not being there. So let's go through a couple things here real quick. Secondary to or due to are the words you should use when you want to say there's cause and effect. If you say in the setting of, you're saying they're both present at the same time, but there's not a cause and effect. And it makes a difference because sometimes there's what's called a combination code that says these two, when they have a cause and effect, have a higher severity or higher risk of mortality or both. So you want to make sure that, and most of us say secondary to. So here's another case. You might find other ones in here, by the way, that are incorrect from a clinical perspective, and I apologize for that. I don't know the difference of some of these. My point is to show that when the coding was done, this is the result of the change that was there. And again, this is something that happens pretty much everywhere. So this one that didn't change the principal diagnosis, what changed was a secondary to. So the spinal cord tumor was the cause and effect of the neurogenic bladder. When they answered yes, that was, they went to a different DRG from 2.43 to 2.95, 2.7 days to 3.6 days expected length of stay. The severity went from 1.82. So this is a 50% increase in the severity rate on the basis of secondary to or due to. It makes a difference, and the severity went up to a 2. And then this is often, for surgeons, this is less of a big deal because this, when you say probable, presumed, likely, or suspected, you say, I think this is what it is, and that's how I'm going to treat them. For surgeons, you usually get to find out. So if you suspect that it was XYZ, and then your path report comes back ABC, then you can say XYZ was ruled out. The patient has XYZ. But typically, we're going to get to see what it is that's there. These words are not the same. Concerned for might be, cannot rule out, worried about, even possible. Those are not synonyms. Those are differential diagnosis words, and there's nothing wrong with saying differential include. It'll be codes, so it's not going to be assigned any severity associated with that. Okay, so let's look at real quick how you look to the world. You've probably looked at health grades, by far the #1 site that the public looks at. Their methodology is that 5 stars, the top 5% of the nation, 1 star is the bottom 5% of the nation, and 3 stars, the middle 90%. There is no 4 or 2 star in the methodology. This is a rolling 3-year average. The 2024 report says, and this is Harvard View, and this is Montlake. The 2024 report is 20 data from 20, 21, and 22. When the 25 report comes out in a couple months, probably March, February, March, then they'll get rid of 20 and they'll add in 23. So for instance, for the cranial neurosurgery, if whatever happened that made it 1 star was in 2020, and it didn't happen again in 2023, then that will hopefully move up. Make sense? Okay. This is what the public sees. Does anyone think this is true? There's almost no way it's true. But this is what is there because of the words, the lack of expectation of mortality. This is from Care Compare. This is the CMS website. You go to cms.gov and you can get to Care Compare. Serious complications. This is for all surgery, not just neurosurgery. Very close to the national average in both cases. So they'll say no different than the national rate. If it's better than, they'll say, if it's more than 1 standard deviation, they'll say better than. If it's more than 1 standard deviation below, they'll say worse than. Okay, so let's look at some comparison data. This is for Montlake. HD is hospital data from 4/23 to 3/24. That was the latest data that we had in this comparison. MP is MedPAR data. That's the government database. The 2022 is the last version that they had released. And so this is comparing MedPAR 22 with UCLA, with Stanford, with UCSF, and with UPenn. And you can see for surgical case mix index, you can see how you look. Now, this is a fairly significant increase between this time and this time. That can be because you started doing something that had a higher relative weight you didn't do before, or it can be because you're better documenting that your patients really have been higher all along and you just weren't getting credit for it before. This is looking at the mortality. So you can see 18% lower mortality. That means the numerator is 18% lower than the denominator in the mortality O/E. You can see for the other hospitals similarly what it is there. And if you look at severity, this is saying, oops, I did the wrong thing here. This is saying that your patients are 51.7% more severe, more complex than the average in the state of Washington. Well, that should be that way because the average goes from critical access to academic university medical centers, and you're the pinnacle of that. So you should be as high as it's going to be in the state of Washington. And you can see again for others. Now, this is also improved from what it was in 2022. We can drill down deeper and we can look at neurosurgery for mortality. This is from Montlake. 259 neurosurgery patients. These are DRG maps. That means that this patient had a neurosurgery diagnosis, which went to a neurosurgery DRG. As an example, if a hospitalist admits a patient who has heart failure and they never see a cardiologist, it's going to go into the cardiology bucket. If a general surgeon does a thoracotomy, it's going to go into the CT surgery bucket. I say that because probably not going to be a lot of surgeries that are going to be mixed. I don't know actually for UW, I don't know if you know where spinal fusions go, spinal surgeries go. Sometimes they go to ortho and sometimes they go to neurosurgery. And I believe that they go to neurosurgery at this facility, but I'm not positive about that. So what are we showing here? We're showing that of 259 patients, 4 of them died. That's an actual death rate of 1.54%. The documentation said we expect 12 patients to die. That's a mortality of 4.52%. Which means that you had 8 fewer deaths than expected. That's 65% fewer mortalities than expected, which is excellent. And you contributed very significantly in a positive fashion for Montlake for that to be the case, for that to be 18% below. You can see that some aren't there. For surgery, 12% higher mortality than expected. Is the problem this number or is the problem this number? This is documentation. This is actual. So the problem, this isn't bad at all, but this is very, very good for being an academic university medical center. The problem is the words in these cases are not representing what is going on. It does seem that for neurosurgery that they are. This is for the severity of illness. This is saying that your patients, this is the average in the state for neurosurgery, 2.59. Here's 2.7, so that's 4.4% higher. If you're the pinnacle of care in the state of Washington, then this number probably should be somewhere at least at 15 to 20%, which would even go further towards this 51%. What's the key? The key is secondary diagnoses that are affecting the severity of illness. Remember the APR-DRG, 1s, 2s, 3s, and 4s. Some of your 1s should be 2s, some of your 2s should be 3s, some of your 3s probably are 4s. So now this is looking at Harvard U, just so you can see comparison. I'm going to go through this very quickly because we don't really have time. Now this is different comparisons. Zuckerberg, Brady, Hennepin, and Parkland. And I don't know who chose these, but now you can see comparison of some more nationwide circumstances there, favorably comparing. For mortality, different from what you saw for the other group, the other grouping, and there's some obvious work that needs to be done. I can tell you for certain that Parkland has, just like county in LA County, has terrible documentation And so they're not getting credit for the complexity the patients are taking care of. Severity, 32%. I'm sorry, do the same thing again. I'm not used to this. So 32% higher severity, which is improved a little bit from what it was previously. These hospitals have some work to be able to do because all of these are tertiary and quaternary care centers. So for Harborview, 9 point, I do the same thing again. This is not my usual changer, I'm sorry. So 9.4% higher mortality than expected, 70 actual, 64 expected, 484 cases, 14.4%. Your documentation says 13.2% expected mortality. Now, again, depending on the cases you have, this is not an issue necessarily. This is a problem though, the documentation. Now, this is not a lot, 6. And overall, there was 11 for the whole hospital. There was 11. But you can see 6, if you took just these two, just neurology and neurosurgery, the neurosciences, this would go, if they were at 0, not even better than 0, if they were at 0, then this would go to 0, and this would be instead of higher than expected. Does anybody have any questions about that?
This is maybe more of a philosophical question, but like for a lot of neurological diseases, death isn't necessarily the worst outcome.
I agree.
And so,
Point,
like
point well
this,
taken.
this would push us towards keeping people alive who probably
Yeah.
shouldn't be.
However, remember, this is not about the actual number only, it's about the denominator. So patients who you allow to die because it is the better outcome for them, you still have an expectation for why they're dying. So a patient who has a brain cancer that's had it for 4 years, they've been in and out of the hospital over the course of the 4 years, they've had multiple treatments, they've had surgeries, and they get admitted today and they're going to die in this admission. The numerator for mortality has always been 0 for the last 4 years every time they got admitted. This time it's going to be a 1. Are they dying just of brain cancer, whatever type of cancer it is? They're dying of something, other things as well. The brain cancer is affecting, maybe they have acute respiratory failure because the mass is now encroached into their respiratory center and they don't have respiratory drive. If we don't say the acute respiratory failure, secondary to the whatever the malignancy was, we're losing off on the expectation of mortality that acute respiratory failure adds to that. And those are the kind of things here. The other question is, you had made a couple of comments related to the semantics. I use a term called semantic modifiers. Those are words like mild, moderate, severe, or chronic, subacute, acute, or stage 1, 2, 3, 4, 5. That's not tumor staging, that's staging like CKD. Sometimes the word severe moves them from a 2 to a 3 or to a 4. And we could say malnutrition, and malnutrition has a severe, has a risk of mortality of 1, but if you have severe malnutrition, they have a risk of mortality of 3. So the semantic modifier is important. You wouldn't know that, but if you got asked in a query about it, that's what they're telling you. They're saying there's a difference between these, and we're letting you know that, and you can say, oh, okay, severe malnutrition, which is really just an endorsement of what the expert said, the dietitian. Okay, so from severity of illness, this is saying that your severity of illness here is 21.3% higher. I think at Montlake it was 4.4% higher, so 21.3% higher. That's more like where it should be. Here's the average in the state again. There's yours here, 3.1406. This comes from principal diagnosis and then the secondary diagnoses your patients have that contribute to an increased severity in this case. The other one was risk of mortality. Okay, so documentation details. Whose job is it? It's the attending's job, even if the attending doesn't generally do any of the documentation. Still, the attending's legally responsible for the accuracy of the record. Now, that doesn't mean you're responsible for diagnoses made by other people. As you said earlier, it means you can endorse diagnoses by saying, the person who made this or the service line that made this, they're experts in that area. When you endorse a dietitian's diagnosis, you're not saying I'm a dietitian and I can make the diagnosis myself. You're saying they're experts in that area. I don't have reason to disagree with it, so that's a diagnosis. They can't code from the dietitian consult because they're not privileged by the medical staff. They do have hands-on care, but they're not privileged by the medical staff. Okay, so let's talk about complications. How are we time-wise?
Like 2 minutes.
Okay, yeah, so we're not going to get done. You are all going to get a PDF of the slide deck, though, so you'll be able to go through these. Complications, something that arises unexpectedly and was directly caused by the procedure itself. Now, the problem is that we use the word complicated or complicates the case when we say something confounded the care. It made the case more difficult. That doesn't mean it was oops, but to the public, complication complicates. Complicated means oops. That means when any profile goes out there that is measuring occurrences or something that made the case more difficult, we're getting dinged as though it's an oops. So I want to make sure and point out this because if we ended right here, you probably make difference in your complication rates. If somebody says post-op in front of a diagnosis, like post-op acute lymphedema, that allows a complication code to be assigned. There's a code for acute lymphedema, and there's a little T code that says this episode of acute lymphedema was an oops. That's not what happens most of the time, but that's exactly what happens when it comes to the dinging you for something that isn't really, you really shouldn't be dinged for. So my advice is, tell your folks within your service lines, don't say post-op in front of the diagnosis. Say acute lymphedema, say atelectasis, say whatever it might be, acute respiratory failure. But when you say post-op in front of acute respiratory failure, it's automatically a patient safety violation. PSI, it's publicly reported. Anyone in the quality committee here? Yeah, see, I could see you're shaking your head. Yes, I figured. It's a patient safety violation, and you do a surgery when the patient's always on event when they go to the ICU, and then your intensivist colleagues say post-op respiratory failure because they're on event after surgery, and you get a PSI as well as a complication. They shouldn't be saying that. There is a diagnosis of pulmonary insufficiency following surgery, which is not a PSI. It still pays for event management. I know it's a semantics thing. I get that completely. By the way, you all just saw a demonstration why I like it when you're here as opposed to being online, because I can see you shaking your head, and that allows me to answer the issue. The issue is that we don't make the rules. We just get dinged by those rules, and if we don't know them, we can't play that game. We can't compete, and then we end up not looking like we should look, which is why I kind of have a passion for sharing this information. I think we're a lot better than we get credit for, not even just as a UW, but also as a state, as a nation. Our medical care is better than we're getting credit for because we didn't learn how to use those words. Okay, so that's a major thing here. Here's just some examples. Post-op in front of any of these can allow a complication code to be assigned. Just don't say post-op. Say post-op day one in the title of the note. Then everything after that was on day one, and you're fine. Any of those. You can say this was expected. Until I think 2011, if you did a nuchal stenosis procedure and there was a dural tear, it was considered an oops. And then I looked into this, and it looked like it was about 50% of the time there were dural tears, at least at that point, and they were all getting dinged. That's not an oops. When you do the procedure, if it happens commonly occurs, by the way, those are words you could say. You could also say reasonably necessary to accomplish the surgery or integral to a difficult procedure. For neurosurgeons, these are important words because you have to go through this to get to that. Sometimes when you go through this, you're going to end up with a deficit. It's not an oops, it's what had to happen in order to get to what you needed to do that was life-saving for the patient. I mean, I'm very fond of saying to neurosurgeons, when Ben Carson separated conjoined twins in the brain, there was going to be deficits in both of them. Nobody knew what they were going to be. They're not complications. That's what happens when you did that type of procedure. Okay, so we're pretty much out of time. We talked about this already. Post-op respiratory failure is a oops all the time. Full-on ventilator management is coming from the acute pulmonary insufficiency following surgery. So let me just show you. You can see this when you go through chronic respiratory failure. If a patient comes in to see you in the office and is on oxygen, that patient almost for certain is going to end up on vent in the ICU afterwards, but not necessarily because of their surgery, but because of their chronic respiratory failure. So if you have a patient that's on oxygen and you say, are you on that all the time? Yes. The second question you should ask them is, what happens when you're not on? I turn blue. That's chronic respiratory failure. I got the definition from the pulmonologist in the clinic. They require supplemental oxygen to keep from becoming more hypoxic. There's your PSIs. So these are the ones that ding you. Postoperative respiratory failure, death among surgical patients with serious treatable conditions. We looked at that one earlier on. Accidental puncture or laceration. So if you say there was an unintentional, whatever it was, depending on the circumstances, unintentional might be a complication. But it might also be that we had to do that to get where we needed to get. So the words that you use are going to be important.
If you have a CSF leak in a spine surgery and you say it's due to like scar tissue and adhesions, does that reduce it as a
That was
complication?
reasonably necessary to accomplish the surgery. I've left a lot of uterine cirrhosis on the bladder or the bowel to prevent the opposite. So it's part of what you need to do to accomplish the procedure. But when you say inadvertent tear, so the software that the people who are working with Brock and also the coding professionals, the software now with the digitization of the records, it puts a block around the words. And then they look at those words and they say, okay, we got to figure out, was this a complication or was it something else? And that may lead to a query. And not answering the query, the default is it was a complication. That's the problem with not answering the query. Okay, I know that any other questions? I know we're out of time. I appreciate your time, and I know there's a lot of information. Any other questions that anybody has? I see a lot of faces here, and I recognize that this is not something that we look forward to. On the other hand, as we discussed a little bit ago, I think you're going to see better and better use of your resources that are going to allow your process to change without having to be as significant.
If we put sort of semi-related diagnoses into, that's like the highest touch point for us, right? So patient has respiratory failure secondary to the rating. Does that, and that doesn't necessarily get propagated to the discharge summary? Does that still count as being from within our HT discharge summary?
So technically, they can assign a code, but only if they see the clinical validation of that, and you probably aren't going to put it in your operative.
Yeah.
Acute respiratory failure is evidenced by a SAT that was this, or a ABG that showed this. That's not going to be there. So the better place to do it is in the assessment plan problem list for a couple of reasons. One is because you can usually use the clinical validation there. Diagnosis is evidenced by, and then it also is already down there. It's going to move forward and make it into the discharge summary, which means you don't even have to say it in your operative note, unless it was a oops, which is probably not the case, and you put it under complications. That's the other thing, by the way. Any diagnosis you put under the complication heading in your operative note, it's going to get assigned that little T code that says this was an oops. So just be aware, you know, it's appropriate if it was an oops, as I said. There are complications that everybody has at some point.
We
Okay.
better wrap up, but I want to just thank Dr. Catalano again for taking the time to join us today first.
A lot of food for thought here.
Just remember that your CBI team is your backstop. They're the member of your team whose job is to help you get credit. So don't ignore that. Tell everybody that you're working with training wise, advanced practitioners, everybody, when you get a query, you need to be considering it.
And I think the second part is, based on sort of this groundwork that started at UW Medicine, people like Diana and our consultants and our infrastructure teams that are working on this, we're going to try to create some solutions using our EMR, IT, and hopefully AI, like evidently in other software programs that might add value to that. But we really need to think about how we can meaningfully change our workflow so we can accomplish these kinds of things, which is not straightforward for us at this time. And it's sort of a little bit of federal and state problem, or it's a little bit of the system, a little bit of the service line. And we can only create so much at our level without gargantuan amount of effort from our epic leaders and so forth. So we really need to sort of think about how we can achieve this without disrupting our efficiency and our productivity and so forth.
The best part is you're going to be able to see a change. You will be able to see a change in the fairly near future. You're going to see these numbers move up and move up.
More to come. And then the last part is Mike's question was a very good one. Totally separate discussion, ongoing, a lot of work being done in that regard at our system level. But again, that will happen too. So don't worry about that, Mike. That's going to happen. So
I'm sure there will,
different.
I'm sure the beatings will continue until morale improves, but
Worry about it.
yeah, I mean, yeah, it's a carrot or stick thing, but if you don't either incentivize good behavior or disincentivize bad behavior, then this is very important, but lacks salience to anybody in the room.
What I find is this, I
That's very
find that
hard.
especially for surgeons, we are very particular about how we look compared with other surgeons. And so ultimately, as you start to see some who are engaged start to move up, then others will say, well, I don't want to be left behind. And behavior changes on the basis of peer pressure. It is, that's what we do.
So it's a little different than that. We're not talking about carrots and sticks here. We're talking about, how the system literally gets paid will be different. Therefore, the way in which that money flows through the system will have to be different.
Well, of course, that makes it much more salient, right, for everybody. It's just a question of downstream effects, right? And I'm sure we'll talk about this differently. Like, I'm sure we will care. I'm sure it will affect us, but it is hard, especially for trainees, to care about any of this because they're so far removed from this process and so far removed from the effects. But they're the ones who are actually doing it. So unless you want to shift even more of documentation and coding and burden onto the attendings along with everything else, it's going to be very difficult, as you said, to make this change. Operationalizing
So
it is
this
very
meeting,
difficult.
this meeting was so important is because you have attendees and people who are trained here as well. They see you're saying, you know what, this is important. Even though we're not the ones doing the work, you're doing it. You need to be doing it this way. If you weren't here and I was just talking with them, they'd come back to you afterwards and say, you want me to start changing what I'm doing because of somebody who I've never
They
seen?
don't listen. So
That's a great point, because I think our residents definitely be affected by this in their
Yeah.
careers. Just like EMR is their life, they don't even remember what paper, they don't know what paper looks like. So you have to learn this because you will be impacted. Dr. Levin, myself, sure it'll affect us to some degree. If you're a spine surgeon, it's definitely gonna affect you, for example.
maybe not vascular, maybe not, we'll see, but the young people in the audience, absolutely part and parcel. Just like RVUs has been part and parcel of our careers, this is gonna be your RVU.
Absolutely. Thank you again.
Thank you so much.